In this video, we'll review BiPAP for the Hamilton T1. For the overview, we'll look at a very abbreviated anatomy and physiology, a generalized indication for BiPAP, how to actually apply the BiPAP, and then some quick caveats and tricks. For A&P, I want to talk about how BiPAP actually helps the patient. So there's three things. It's a VLR recruitment, a VLR stretch, and then increased oxygen. For a VLR recruitment, what this means is you have collapsed a VLS and they pop open under pressure from the BiPAP. So opening, close the VLI. For a VLR stretch, it's easier to pass gas, in this case CO2 and oxygen, across the membrane if it's thin versus if it's thick. The analogy is if you have chewing gum in your mouth and it's thick, there's no bubble in it, it'd be harder to pass oxygen through that and CO2 versus if you blew up to very thin where you can almost see through it. It's very, very thin. It's easier to pass oxygen and CO2 through that. Increased oxygen percentage, also known as FiO2 or fraction of inspired oxygen. You control from room air, 21%, all the way up to 100% with the ventilator. So you're opening VLI, you're thinning the membrane out or giving the stretch, and increasing the oxygen percentage. This is how BiPAP helps. For BiPAP indications, we'll talk about it very generalized. I want you to think about using BiPAP in three scenarios. Hypoxemia, or low levels of blood oxygen, hypercarbia, high CO2 levels, and pulmonary edema. I want to tie in the shortness of breath approach video here. These are the people that are in extremis. So they're on the line between needing intubation and not needing intubation. BiPAP can absolutely turn them around. Hopefully by the end of this video, you'll feel more comfortable about doing BiPAP trials or applying BiPAP to anyone that you think needs it. For BiPAP application, as with all things, the key to success is setup. First, I think giving somebody 0.5 to 1 of Ativan while you're getting everything out and set up will help greatly increase your chance of the patient-ventilator synchrony or working together, which will actually help improve the breathing. Next, get the patient positioned. You want them to be in high Fowlers or just slightly semi-Fowlers, near Fowlers. This will give you the best position to get the weight off the chest for good inhalation and good exhalation. Next, have the ventilator prepped. All the tubing connected, all the checks done, have all the settings applied and put on standby so all you have to do is hit start ventilation when you're ready. Lastly, make sure you have an appropriate size mask, same as a BVM. It's got to cover the corners of the mouth and have the head strap prepped. You'll be placing it in your hand when you go to put this on the patient, so just get it out next to your mask. Last thing is I have a recommended phrase. Often you'll hear people say, this is really going to suck or it's going to be really hard. If you're having a hard time breathing, that is the last thing you want to hear. So let's read this phrase and see if you think it's a little bit better. I want to apply this mask that will make it easier for you to breathe. I promise this will help you if you work with the machine. All you have to do is focus on slow inhalation and slow exhalations. I'll start by holding the mask before I secure it to your face to ensure it's improving your breathing. BiPAP mask application. One hand, head strap, other hand the mask. Then start the ventilator. Back of the head, mask, bridge the nose, make sure you encompass the entire mouth. How's that, Mr. Sanchez? Are you able to tolerate that? Yeah. All right. Can you grab the mask that we talked about? Perfect. We're just going to start off where it's lightly snug. Cross pattern. Okay, I have the mask. Okay. You can already see it's pulling off its post. Perfect. I'm going to run my fingers around. It's already pulling. All right, run my fingers around. I don't feel any obvious leak. Then we'll go to the monitor. Monitoring, page 2, V leak, 0%. To set up BiPAP, when the ventilator boots, it'll be in ASV mode. So first thing we're going to do is click Modes. Down here on the non-invasive, which is meaning CPAP BiPAP, we select NIV for non-invasive ventilation. Confirm. And we're going to set the P support at 5. The PEEP will already be at 5, and then we'll set the oxygen to 100%. Don't worry about flow trigger. We're going to confirm the settings. It's helpful here to put in the patient height, and say in our case example, the patient was 5'10", so 70 inches. And then we'll hit start ventilation. Check our monitoring tab for a V leak. Goal, less than 30%. For documentation, you're going to record what I call a balance sheet. These are the items that you're going to record every 15 minutes or sooner if you make a change. So let's start with a list. P-peak stands for peak pressure. Min-vol stands for minute volume, in this case, the expired minute volume. VTE stands for expired tidal volume. F total stands for frequency total, aka the respiratory rate, how many times they're breathing per minute. And lastly, V leak. V leak stands for volume leak, which means do you have a mask seal leak? We're looking for 30% or less. That's typically someone that's fat, has no face or teeth, or maybe a large beard. Generally speaking, you can get this below 10%. The other two things that you'll need to record on the balance sheet are SpO2 and end-tidal. After you have the BiPAP applied, let's review what to monitor. We'll review and record the peak pressure, the expired minute volume, the expired tidal volume, and the frequency or the respiratory rate. Same thing in this case. Next, we'll hit Monitoring tab, page 2, and we'll record the V leak percentage. Reminder, the goal is less than 30%. What we're really trying to do is we're trying to match our calculated minute volume from the ventilator triangle and the calculated expired tidal volume from the ventilator triangle. The key to this is, since we're not controlling the rate, you need to adjust the tidal volume to that number you calculated, the 7 ml per kg evaluated body weight. That is done by adjusting the top number, the pressure support. If it's too low, you need to increase this number. If it's too high, you need to decrease this number. If the number is way, way too high, you can always go to 0, and it's the same as applying CPAP. Generally speaking, you want to make adjustment 1 or 2 at a time. So we're not going to go from 0 to 10. It's 2, 4, 6, and so on. We've reached our target tidal volume, but we still have an oxygen problem. So what we would do is we would leave the pressure support number alone and increase the PEEP by 2 at a time. Same rules apply for BiPAP as it does for ventilation. We're going to wait for equalization. So we make adjustment of 2, so from 5 to 7 in this case, and we will wait until the SpO2 stops moving. So say it goes from 88 to 90%, then we'll make another adjustment. To provide inline nebulization, you must use the Hamilton inline neb function. This button in the bottom right is a nebulizer. When you push it, you'll get a green light, meaning that it's going to provide nebulization only during the inhalation phase. The top left port here is the nebulizer port. It's larger and yellow, when compared to the flow sensor ports. Your nebulizer only connects to this port. Caveats and tips. Ativan administration. In order for the Ativan to work, you have to give it time to take effect. Typically speaking, we're looking at 3 to 5 minutes for Ativan, so give it early and give it enough time before you put the mask on. If you give them Ativan and put the mask on immediately, it was done nothing. It will not help them, and your chance of failure is much higher. Ensure mask seal. Oftentimes I see, especially when we pick up out of the ERs, is either a huge mask or a tiny mask. You need to ensure that you have a good mask seal or it cannot work. Air will always go to the place of least resistance, which usually is out the mask and not in the lungs. BiPAP trial failure. If you apply it appropriately, say the right things, give the Ativan, you're really just going to return to baseline, how you found them before you did the BiPAP trial. You should not be scared to put this on somebody. It can really help them, and so I encourage you to try it if you think they might need it. If the patient were to stop breathing, the ventilator will deliver breaths. Hit controls, apnea, and you'll see here the backup mode is PCV+. It's going to deliver a rate of 12 with a pressure control of 15 and an IDE of 1 to 4. So this will happen if the patient stops breathing.